So let me ask a question. Who in this room has had to deal with a dialysis claim? Okay, only 3 or 4. I can assure you that those 3 or 4 wish they probably would have done something before the claim appeared. Would that be a fair statement to make? Everybody in this room is a stakeholder in this process. And we call it the jack-in-the-box effect, where remember the little thing, and the jack-in-the-box pops up. That's what's happening in the world of dialysis claims. We believe you absolutely have got to be proactive. And as we go through this process, you're going to understand why we say this. Tom and Marcia, it's very obvious by the people who have talked to you over the last day and a half, have discussed about best in class. And that is such an important thing because they have proven they save money by using best in class. And as we go through this, you're going to see that DCC is a member of that. We've been in business for 12 years. We are experts in renal care cost management. There's another logo on there called Renal Logic. We instituted this program as a means to not only, we've been managing dialysis claims for a while, so now we're going to get to the front end. And we're going to talk to you about the importance of data management. I assure you, I'm not going to show you a bunch of slides of how our data is so good and all of that. We're going to talk conceptual today, except for the case studies. Shelley, will you please stand up? Shelley Grace, our EVP of Sales, is over in the corner there. You can corner us at the, what's the name of the place again, Tom? The boiler room. This is a scary slide. See these numbers right here? There's a term that says LDO1 and LDO2. LDO stands for Large Dialysis Organization. That's, for those of you in this room, they are DaVita and Fresenius. I'm seeing some nods, so you've heard of those people. They have, folks, they have more than 85% of the dialysis patients in the United States. Go back to your marketing 101 in college. What does that mean? It means they're charging here. See this number right here? That number is $331. That number is what is the Medicare allowable amount. Okay, that's what Medicare pays DaVita, Fresenius, and their brethren. But, oops, sorry about that, but they charge, their bill charges are approximately $4,000. And what this is, folks, is a per claim. This includes lab and RX for what that's worth. But they charge about $4,000 per claim bill charge, which equals out these days, we're seeing about $60,000 a month in billed. That's over $700,000 a year. For those of you that have not experienced that, it's going to happen to your clients if you're self-funded. It's going to happen to your clients if you're fully insured. It's going to happen. Now, dialysis, one of the reasons why so many people, in our opinion, are reactive instead of proactive is because it's not a rare claim, but it's not a consistent claim. And we all get busy, we all stop thinking about what's going on, and it's not on the radar until such time as it becomes on the radar in the jack in the box. See this number right here? 50580. That number is the actual revenue per claim that DaVita and Fresenius receive. So stop and think about that a minute. Wait a minute. They get paid $505. Medicare is $331. The commercial payers, the people in this room, are paying that difference. And someone made a comment in one of the earlier presentations about how they're already screaming about the Medicare reimbursements that they receive. They're still in business, they're still growing. They're making money on Medicare, no question. They're making huge amounts of money on the people in this room and your clients. This is a public information, what I'm about to tell you, because DaVita is a public company based in Denver. The CEO in the 2013 annual report, CEO received $29 million in compensation. Not one penny is paid in true private individual. All of it's either Medicare or the commercial payers. Something wrong with that. I think you guys would agree. But it's not just dialysis. One of the things we've learned in being in this business as long as we have is that what is the best way to reduce the cost of a dialysis claim? Stop a dialysis claim from even occurring. Right now, as you can see up here, the first two, and I know sometimes it's very hard to see these things, the big thing about chronic kidney disease with the comorbidities that are going on, and any of you that have experienced this process, keep in mind that CKD very seldom happens on its own. Other comorbidities, it could be hypertension, it could be obesity, it could be diabetes. Over 40% of the people with diabetes have CKD. What we have found is that hospitalizations increase dramatically when CKD is involved with one or more of those comorbidities. We can help stop those in a program, our CKD management. I'm going to give you a stat. For those of you who can't read this, 43% of the patients that go on dialysis have never consulted a nephrologist. Now, it may not be fair, but I kind of compare that to having a heart bypass and never having seen a cardiologist. I mean, that's a scary thought, folks. 43% of the people go on dialysis, which is one of the highest claims in existence, and they're being managed by who? DaVita and Fresenius. What does DaVita and Fresenius want to do? They want to make money. So, this program, we're going to talk more about the Renologic program in just a moment, but keep in mind how the importance of managing folks. Because one of the things to keep in mind big time, I'm going to need some water here, I can feel that. Tom, would you mind? Thank you. One of the things to keep in mind, CKD, chronic kidney disease, is a progressive disease. Thank you, sir. Appreciate it. And by that, we mean this. There are 5 stages of CKD. First and second stage, diet and education can control it. Once they hit stage 3, they're really getting sick. Stage 4, they're really, really sick. Chances are they're going to be in dialysis within 3 to 6 months if they're not managed. Stage 5 is the end stage where they actually go into dialysis, okay? The reason I bring that up now, you'll understand in just a few minutes. So what do? We don't, repricing dialysis claims, do we do that? Yes, we're really good at it. Well, I'll show you something about that in a minute. Our payment-based UNR, our payment-based UNR down at the bottom, That's our most effective program, and I'm going to talk more in detail about that. We also do single patient agreements when you have a patient that we can't put in the payment-based UNR. But one of the things that we pride ourselves on, and is very important, is the home modality, which we mean doing dialysis at home. The U.S. system is backwards when it comes to dialysis. Less than 7% of the people in the United States do dialysis at home. In Europe, it's higher than 80. And one of the reasons, if not the key reason, is because you have two providers who make big bucks on doing in-center. However, if you think about it, driving 15 miles, getting into what we call into the chair, you've seen photographs or video of people in a dialysis place. They're all plugged up. They go in there for 5 or 6 hours a day, 3 to 4 days a week. That's their life. Well, if you can do it at home, maybe you do it, and you do it 5 or 6 days a week for that 3 or 4 hours. You do it at night, you work during the day. And the biggest thing is, the quality of life in a home modality setting is so much greater, plus you live longer. Now I'm going to make a statement here, it's kind of cold, it's kind of scary. When your doctor tells you you have to go on dialysis, your doctor just, on the most part, has given you a death sentence if you don't get a transplant. That's scary, folks. Everybody in this room should think about that because this is a people thing. When it all comes down to it, we're treating people. And if you can do it at home, it's been proven you live longer, you have a better chance to get a transplant. We push this process big time. That, by the way, is in the Renologic program as well. The other thing where we separate ourselves, everybody does data. We get that. But one of the things, and I'm going to show you a slide later in the presentation, that shows you, we have put together, it took several years to build this, but the algorithm we have built, we are identifying people, and you've heard the type of data review and data mining that Tom's vendors use and provide. I'm going to show you a slide that's going to blow you away. It blew Tom and Marshall away completely. Would that be a fair statement, Tom? Okay. So, dialysis. That's the big cost, $700,000 a year. We don't do Medicare Plus or Cost Plus or anything like that. We're not going to have that conversation. What we do is a true UNR. We provide a planned language to go into the plan doc. It just plugs right in. There are no networks, no contracts, in and out of network works. Any facility, doesn't matter because it's a UNR. And it's a payment-based UNR. It's based on, remember that $505 that was on that slide? That's what the initial basis of the algorithm we use, that's what they're paid. They have to file that with CMS every year. So we base our UNR off of that. We include what BUCA pays and Medicare pays and Medicaid, so that what we pay is a true UNR. The language, we've developed it through the years. It's been tweaked off and on. But bottom line, we've had over 1,000 appeals and we've never lost one. Pretty much now, the only appeal we ever get is DaVita. You'll love this. It's the same letter. Every claim we have with DaVita that we work on, we get an appeal, first level appeal. It's the same identical letter. It doesn't matter what office or what place it comes from. That's kind of sad. Someone at DaVita at the top, in my opinion, this is Jeff talking. My boss is Marcia, I can't believe he's going to say this. My guess is somebody at the top said, just send it to them, no matter what. But the point is, we have never lost an appeal, which, by the way, if there is an appeal that occurs, we will provide some support for that appeal. The great thing is, we provide an average savings on gross billed of 85%. That is data proven, and again, as I mentioned, it is appropriate for in and out of network. The last one, very important. ESRD is only one of 2 diagnoses that Medicare covers. The other, by the way, is ALS. But ESRD is one of the only 2 diagnoses covered by Medicare for under age 65. Now, all the individual has to do is get Medicare Part B. We do help them do that. Sadly, DaVita and Fresenius and their brethren discourage people from getting Medicare Part B, which is really sad, but they do. The point is this: when they get enrolled in Medicare Part B, and they have a 90-day period from the initial diagnosis to do so, they get on Medicare Part B. Now, the plan's still going to pay a primary. Since we're paying the Medicare allowable amount, by law, DaVita and their friends cannot balance bill the patient, so that issue is off the table. Any questions on that? Because that kind of can get confusing. Okay? And with that, I'm going to turn it over to Renee. You want this, Renee, or?
No, I'll just use the computer right
Okay.
here. Thank you. Can you hear me okay? Thank you. Okay. With the information with DCC, there's a couple ways that we share the information with them that they help us identify, or that we can help them identify a member. I've got a couple cases that I'm going to review with all of you. That this first one was actually a new client that came to us, and they were already aware of their one employee with end-stage renal. For this one employee, I'm going to actually talk about them in a 2-year. We went through a renewal with them already as well. Employer size is about 70 employees on the plan. They had a $30,000 individual specific. Again, they had that one end-stage renal patient, and they did get placed a laser. At this point in time, the plan as well with this member, as Jeff has mentioned, with Medicare, this plan was still primary over Medicare on this one member. The total billed charges for this one employee on just their dialysis treatment was over $581,000. The plan payment for that plan year was almost $175,000, providing over $400,000 savings with the dialysis, the repricing in the UNR, averaging about 70% savings for them. Also, I just wanted to mention too, with the $581,000, that represents about 50 treatments that they had gone through, almost going once a week. The total plan payment on this individual overall was just over $225,000. So that's in addition to their other treatments. So again, this is just specific to the dialysis treatment. For this employer going into the second year then, on their renewal, still about the same size employee base, they did increase their specific by an additional $5,000, but with that renewal with their stop-loss carrier, they did drop the laser for the second year. So they were included at that individual specific of $35,000. We're only about 9 months into the contract even right now with this member, and Medicare did become prime throughout this time as well. But total bill charges so far for the dialysis treatment was just over $181,000, and the planned payment so far was at just almost $53,000, net savings of $128,000, again averaging about a 70% discount of the bill charges that were coming in from the provider. This represents about 12 treatments that he had gone through as well. And again, did have an additional dollars paid out on this plan for this member. Again, this is just truly looking at their payments for their dialysis. And overall, his treatment was at about $75,000 so far for this year. So this one still is going through this plan. The next group that I have that has also gone through end-stage renal member was a group that we had for a couple years. They had about 55 employees on the health plan. Their individual specific was $50,000. They also received, this was a member that was a diabetic, and gradually throughout the years had gone into end-stage renal, and they had placed a laser on this individual of $400,000. For this one individual, his total bill charges were just over $330,000. The plan's overall payment was $93,000 with a net savings of about $237,000. Again, with this one, then it was about a 72% average savings of bill charges. With this member as well, their total plan payment for this plan year was just under $975,000. So this was just his dialysis treatment. But again, substantial dollars for savings with these two plans that we've had. So that's all I've got. Any questions? Yes.
The trigger point.
The turning point of it when it
Yeah.
becomes prime?
Yeah.
I thought about this morning. I figured this question was going to get asked, and I'm thinking it's 30 months or 36.
Am I on? Okay. I'm good.
It's 30 or 36, and then they become primary. And that did happen with this one individual throughout this, the first one that I was talking about. Well, Medicare paying prime, a lot of times what may happen too is once Medicare becomes prime, they may drop the coverage then at the same time. This member was actually, on our first case study, he was on COBRA, and he continued that COBRA payment because obviously of those charges that he had for dialysis. So he was also on COBRA, so when Medicare became prime, he dropped off with the COBRA coverage then.
Hey, Renee, didn't DaVita actually pay the COBRA premium on that?
I do believe the provider was paying his COBRA premium.
Yeah.
The provider of service for his dialysis treatment was paying the COBRA premium.
For DaVita to pay the COBRA than
Yeah.
to accept the $330,000.
Right.
It is, yes. Did you have, was there another question?
What's the average difference you've seen between dialysis treatments at these facilities versus home?
At an in-center is normally 3 to 4 days a week. Home is 5 to 6 days. Now there is I won't call it new, but one of the things that's being done is a nocturnal approach, whether you actually dialyze while you're asleep. That's every night. It's a very low pressure process, and what we mean is the amount of pressure of what goes through your veins. People, and this is anecdotal at this point, but people on nocturnal are saying they basically are living a normal life. They don't even know they have a kidney problem. Now again, that's anecdotal, but what a great thing. Think about somebody going in center 3 to 4 days a week, as opposed to doing this at home and feeling normal. And as I said earlier, living longer.
And if you take that to its conclusion, those people who are on outpatient dialysis who go a couple times a week are sick as hell the other days of the week, and they
Good point,
cannot
John.
work, they cannot live a normal life. And these people who dialyze nocturnally now have basically standard, normal kidney function, and they can get up in the morning and they can go to work, so you have a productive employee.
And think of, one second, think about that for a moment. Doing dialysis at home, the people can still work. They can still live as much a normal life. We have a
Question over here,
microphone.
Tom.
We have a question here, Drew. Okay. All right.
You mentioned something that's intriguing to me about the Medicare Part B.
Mm-hmm.
What is the youngest Medicare Part B participant that you're aware of?
That's a great question. I don't know. Shelley, do you have any idea who our youngest person would have been? Yeah, they have to be over 18, but we don't, it's, it seems to me we had somebody when I first joined DC said it was like 23, but that's just that's a memory guess.
This is a related question, though. We were talking about the people's conditions when they're going as outpatient,
Right?
and assuming that they might have disability insurance in place as well. If they go with the modal process and they can still go to work, then obviously they probably wouldn't be pooling disability payments.
I think I know your question, but can you ask it one more time, make sure I'm
The
clear on it?
question is, if you have a patient that's going through dialysis, and if they're going as an outpatient, the probability is they're disabled from their job if they have
Correct.
disability insurance benefits.
Right.
If they have it at home, and if they live, quote, a normal life, would they still qualify?
They would not be disabled, so probably not. But personally, I would have to believe that someone would prefer to live a normal life than be disabled, than be on disability. That's just me. Yes, sir, you had a question, Kenneth.
I was thinking about his question, though. From a Medicare standpoint, though, ESRD qualifies, so they would still qualify under ESRD under Medicare, maybe not under private disability insurance. Just thought. Quick question for you, just from a home dialysis. What is the criteria for home dialysis? And if it is, has such a great outcome, or the outcome is so strong, why is it not done more often, and who decides when it is or is not done?
Great question. 92% of the people who go on dialysis, and it's not acute, and acute means something occurred, they had to go to the hospital and they immediately had to go on dialysis. So take those people out. 92% of the people who go on dialysis could do dialysis at home. There are four criteria. One is a licensed provider has to oversee the process. Number two, you have to have a caretaker to be there with you when the dialysis is going on. Part of the thing that the provider does is train that person. Third is electricity. And fourth is water. Not a big deal. Which begs the next question, why don't people do it? This is us talking, us being DCC. It is our opinion that, first of all, if you think about it, 43% of the people don't even see a nephrologist, so we know what's happening there. The other situation is many nephrologists have direct connections. We can't call it a contract. They have direct connections with DaVita and Fresenius. The DaVita and Fresenius model is to do in-center. So when the person says to their doctor, can I do this at home? Doctor says, yeah, but, ... It's anecdotal. Make your own opinion. That is our belief. It's sad because, again, if you recall, a minute ago I talked about the number of people in Europe that do it at home. And the thing about it, there are two companies who make the box that you use for dialysis at home, by the way. In peritoneal, there's two types of home dialysis. One's peritoneal, comes through the stomach. The other is you actually have a box. Of course, one of the people who makes the box is owned by Fresenius. But keep in mind, if you think about the three main criteria, if you've got the licensed provider, one of the companies, the box is only about that big. You can take it on an airplane with you. I guess conceivably, if you had water and electricity and your caretaker with you, you can do it on the beach. What a great thought. The problem, though, is the system is skewed. You know, we've been hearing about the system is skewed, not just in the last day and a half, but we all know the system is skewed. It's particularly skewed in this process because it should be flipped. And unfortunately, the system is such that it is not. Any other questions right now before we move on? Okay. Okay. Remember a few minutes ago I made the comment that we did a data review with our algorithm, which, by the way, our algorithm takes into account 150 plus diagnosis codes and procedural events. You've been hearing about the data that Tom and Marcia get all of the time. This is no reflection upon anyone that they work with, their work, or what's being done in the data mining world. What we're saying here and what I'm about to tell you about is the algorithm we use digs so deep, we find people they are never going to find. An example is this. And let me start by saying what we mean by low risk. Low risk does not mean low risk patient. It only means low risk to CKD. It could be cancer, it could be an appendectomy, it could be a car wreck. But that's what low risk means. The program core, that's people at CKD stage 3 and higher. And if you recall, that's when people are really beginning to be sick and they really need to start being managed. Folks, we found 288 people that Cypress did not know about that are in the program core. They are at stage 3 or higher. Notice the cost of that group is 1,300% greater than the rest of the people in their claim shop or in the claims that are in their book of business. 1,300%, and these people, generally speaking, are being managed in some level, but they're not being managed for CKD. And that's really the key of doing this correctly. Now let's talk about what we mean by mid-risk silent and high-risk silent. These are, the term silent means this: they have never been tested for CKD. The moderate risk are those people that have at least 2 comorbidities going on, and we've talked about, I'll talk a little bit more about what those are in a minute. The high risk has 3 or more comorbidities going on. Again, these are people that Cypress did not know about, that we believe, we DCC, believe that at least 50% of those high-risk silent folks probably are in stage 3 or higher. They need to be tested. And as we talked about, the hospitalization cost is so much higher when CKD is going on, and you can see the data versus the low-risk group, how much higher it costs for people with CKD. Any questions on this one? So let's talk about what we mean about CKD management. Basically, these are 5 of the key comorbidities. Most often, the people are being managed for these, but they're not being managed necessarily for the CKD. Remember, it is a very progressive disease. We follow the National Kidney Foundation guidelines on treating these folks. Very aggressive education, and we're going to talk about, we're actually going to show you a video in a moment about someone who actually has used our service. We have a medical director, of course, who gets involved when there needs to be peer-to-peer. The medical director always reviews the treatment plan and so forth. Not going to spend a lot of time on this other than to say we are very aggressive. We know this space. And there is no doubt people with CKD are sicker, have higher claims than people without. It's very clear. So, Tom, would you mosey up in just a moment? We're going to actually show you a video in just a minute. This is an actual case study. Remember I told you stage 4, the person's really, really sick. They're going to go on dialysis 3 at the outside 6 months. Generally speaking, if they're not managed, it's almost a foregone conclusion. Tom, can you go back?
Well, and
No.
Hang on.
Yeah, give me a second to go through the, okay. We got to this person, we reached out to this person, you know, and our nurses reach out, and this person didn't want to talk to us. And our nurse, this particular nurse, kept reaching out to this person because if you look at the top one, it was an acute renal failure at one point, had been to the ER, no doubt they were in stage 4, person was depressed, sick. Finally got this person to agree to work with us in October of 2013. Went through the process of teaching this person everything that they needed to know about what they're having to deal with in CKD, about their medications, about the options of home dialysis, transplant, preemptive transplant. Preemptive transplant is when somebody has a transplant prior to going on dialysis. Was that a money saver? Particularly if you have the organ transplant carve-outs. About how Medicare works, Medicare Part B. She continued working with this person, and within 2 months, or 3 months, by the end of the year, their GFR, and what that is it's called the flow rate. And that's really one of the key things on CKD is the flow rate had increased by 23%. Folks, that is staggering for somebody in stage 4. But the aggressive nature of the management was working. So finally, what has happened, this person was supposed to have a hernia operation, couldn't do it because he was so sick. The medical team has passed on having this person go ahead and have that hernia repair now. Most importantly, dialysis is not imminent. This person has stabilized at stage 4. We know what we do works. So, Tom, can you turn that on now? What we're about to show you is this person wanted to talk to you.
Well, I'm being diagnosed with kidney disease and didn't understand how in the world that they could say I had kidney disease because I'd never had any problems out in the kidney. And the last time I went to emergency room, for that, they said that one of my kidneys had completely quit working, and I have one that is at about 23% now. And it just scared me to death. I didn't know what to do. I didn't know how to handle it. And then Kimberly called me out of the blue and said, I am going to be your coach, your nurse coach with this. And I thought, now that'll be a joke. But it wasn't a joke, because she said, I'm going to send you some material, and I'm going to send you this that shows you if you were to have to go through dialysis, the different kinds that's out there now, that you can actually stay at home and do dialysis. And I'm also going to show you how to retain your kidney function and not lose it, not let it go downhill, let it go up, or maintain the level it's on. And so far, it's been great. The information she gave me, the things to do, I'm still sitting at about 24% with one kidney, but the doctor said I could live till I'm 80, so I'm on that. Oh, I didn't have any energy level. I have a problem with depression. I just suffered with depression for years. When I found about my kidneys being that far gone, I was just on rock bottom. I thought, any morning I could wake up dead. I felt like my life was over as far as it goes for activity or doing anything. But once I got to talking to her, and she'd keep me pepped up, and she'd always want my results from the last test, and she'd always tell me, good things to do and everything. So it picked me back up. She said, your life is not over. You may be able to get by without even having to ever see dialysis. When I think about the future, I think about what, I got chronic kidney disease. It's always going to be part of my future, but it's not going to drag me down or stop me from having that future. Because, I got a team, I got a doctor, I got a team of workers, everybody that monitors everything. And when I think about the future, I think it's bright. I've got 2 children, and I've got 2 grandchildren that I was worried to death I wouldn't get to be with them, be around. But now I'm going to watch them grow up. I'm going to watch my grandchildren grow up, and it's going to be a good life. If somebody else with the same problem were to talk to me and ask me if I would, if I would recommend the program I'm on to them, I would say absolutely, absolutely, because you go from being alone and being scared to having a team out there, and not just one person calling you. I mean, you're going to have one person you do most of your contact with, but that person is on a team, and that team works for you. They work for your health, work for what's best for you, and they'll keep you on course, and they'll give you the best chance you've got to have the best future you can. And I'd recommend it to anybody. I sure would. Now, I would really like to take a few minutes just to say thank you to the team that's on this rhinological program. And Kimberly, you'll never know what your voice means to me when you call, and you're upbeat, and you're talking about how much better that it's getting for me each time, and how you've always got a backup plan if something goes wrong. The whole team I know is doing it, and you guys will never know how much it's touched my heart, touched my life, and how much you've made me feel like I'm not alone anymore. I've actually got people out there that knows what I'm going through. They've seen it before. They know what to do. They're going to keep me on the right track. And it's really, I wish there was some way I could tell you, but I can't put it into words. But you've really been a lifesaver for me, and I appreciate it.
We showed you this for two reasons. One, he really did want to do this. The second thing is, we're in a business, we forget about the people. It all becomes numbers. Would everybody agree with that at some point? It all becomes, we've talked about how much money we're saving, and that's great, we need to. How effective self-funding is versus fully insured of getting control of your plan. But we still talked about it in terms of numbers. That video to me, first I got tears. It's actually 20 minutes he talked. We obviously we'd have bored you to tears with it. But we actually left the last part in. We started to take the last part out where he thanked us directly because we didn't want to sound self-serving. But we talked about it and we felt like, no, that really needs to be in there. Because what it does is it brings the people part of what we do right there. CKD management is very important, and the effectiveness of it is very important. So thank you for watching that. Okay, I'm going to bore you with one slide. Talk to you about the data management. And what this slide is just a very brief example of the kind of reporting we provide anyone who uses the rhinologic program with the data and the data management that we do. I'm not going to go through each of what that means. What those show, though, you will know or your clients will know exactly what is happening, how much money we're saving you, and this is hard dollars. This is not some esoteric thing that we've been talking about, that disease management has been talking about ROI for years and years and years about the soft dollars. These are all directly related dollars that can be proven that we saved. An example, though, is, and yeah, this is the last slide, isn't that great? 50% cost reduction on August through December of 2012. We took over in August of 2013. The program core, remember the CKD3 people? 50% reduction in the medical spend for those same people. This program works. So, we've talked about dialysis. We've talked about CKD management. We unbundle. But most importantly, we believe this has got to be something where we are the risk managers. And that's the biggest term that we want to use and for you to take away is we want to manage the risk of renal disease from beginning to end. So, any other questions?